When you think about learning, there's two different ways to think about it. One is that we start with little bits and we put them together and build to larger concepts. And the other way is to sort of take the bigger ideas and sort of have students break them down and then sort of try to go to that larger concept from sort of a larger point of view. A lot of the learning that we've done traditionally in medical school is looking at those little bits and building on, say, biochemistry or genetics and building sort of little concepts into bigger concepts into even bigger concepts. But the idea behind the case method is to actually sort of take the students and put them into an immersive environment and sort of immerse them in the case, a very robust kind of case, for them to kind of then do the learning that they need to do to solve the case. And it's different for every student. And so you don't really know exactly what the teams in specific are going to learn, but you know that you're trying to get them to the end of solving the case, and then you can debrief it and make sure that they have at least some basic principles coming out of it. What's great about that kind of approach is that it's very student-centric, and that means that you have a higher level of learning because students are learning the things that they become interested in because of the provocative material you're giving them, and that learning really sticks. So what the case-based tool does is it allows students to enter in a list of hypothetical diagnoses based on a clinical presentation. And what we've done with the first-year medical students was use standardized patients to provide sort of a history to get the students started. But you could also, in the case, write out sort of a history to give some sort of beginning information for the case. The students take that information and they write down sort of a list of hypothetical diagnoses within the case tool. They select from a list and a rationale for why they picked those diagnoses. Then in the tool they can go in and they can order physical exams or laboratory testings or special studies to try to take those list of diagnoses that they have and try to do some hypothesis testing and see whether the things that they order either confirm, refute, or maybe refine their thinking. And I think that refining step is actually really important because sometimes their diagnosis is shortness of breath because they have a very sort of high level understanding of what's going on and they have to decide, okay, let me do some testing to see is it asthma or heart failure or pneumonia or some of the other things that can cause shortness of breath. So once they order that information, they press the button and they get information back to them. And now they have to then take that information and resynthesize their understanding of the case based on the information they've gotten back and then refine their diagnosis list and their rationale. And they can go through that cycle of coming up with a diagnosis list and a rationale and ordering some confirmatory refuting information as many times as they want. But once they feel like they've got the final diagnosis confirmed, then they go in and they put in a final diagnosis and they press enter and the case is over. Once that's over, you have to bring the whole group together and debrief to at least sort of get the same learning points out there that was really, from the faculty point of view, the important things. So there is a faculty-driven element to this in the sense that one of the cases we did was cystic fibrosis, and I wanted them to learn as part of the case an understanding of how a single amino acid change can lead to disease manifestations across multiple organs, and understand that this is what this disease looks like that you're learning about at a biochemical point of view. This is what it means to patients and the patient face of this. And so we actually had a cystic fibrosis expert from the university come and talk to the students about that and to sort of drive home those points. But within that context of that learning, there was a lot of other learning that went on by students that went off and either explored different directions of it or explored more specific elements of the disease process to learn about things that they felt was important to them. And I would say I've probably heard from a couple dozen students who have asked if we can do more cases. And they really have a huge interest in this type of learning. It's engaging, they get to collaborate with each other, they have a lot of autonomy. And I'm a big believer in what's called self-determination theory of learning, which is the idea that for students to learn, what they need is autonomy, competence, and interrelatedness. And what the case system does is it gives them autonomy because they're working by themselves. It provides competence in the sense that they get to the right answer or not. And it gives them interrelatedness because in two levels. One, in that they can sort of connect concepts across each other for their learning, but also we had them working together, which is very powerful to have sort of that social experience of learning and learning from each other, which is just a really, really powerful way of getting people to make connections and get learning to stick.